Welcome to Healthbeat, the show that takes the pulse of South Africa's healthcare system. I'm Mia Malan. This September, the United Nations put it bluntly. How do we stop powerful industries from making us sick? From tobacco to alcohol to sugary drinks, these products are fueling a wave of chronic disease across Africa. But every time governments try to tax or regulate them, lobbyists push back. The result? Millions of lives remain at risk.
I've never heard of that in my entire life.
I have no idea.
Non-communicable diseases like cancer and diabetes develop slowly. Normally they come with age, but people who get such illnesses are becoming younger. What we eat and drink, whether we smoke or exercise, and our environment and family history all play a role in who gets NCDs. We're at the Desmond Tutu Health Foundation to meet Dr. Nomathemba Chandiwana. Nomathemba, what is an NCD or a non-communicable disease?
NCD simply is a disease that affects you that is not an infectious disease, like TB, malaria, HIV. When we talk about NCDs, we're really worried about cardiovascular disease, type 2 diabetes, cardiometabolic disease, which is diseases of the heart or of the blood and things that kill you faster.
Is obesity an NCD?
Obesity is a disease, but not everybody thinks so. Some people see it as a risk factor to a disease. So, for example, if you have obesity, it makes type 2 diabetes worse, or it makes your heart disease worse. But obesity is a disease within itself. Type 2 diabetes is the biggest killer of South African women.
And how does obesity look among children?
Obesity is malnutrition. So you could be stunted, which is you're shorter than your height should be. You could be malnourished, which means you are slimmer than your height should be for your age. And obesity is part of that spectrum of malnutrition. We've got some of the highest obesity rates among children, where we have almost 30% of children under the age of 18 living with obesity. And the problem there is having overweight children results in overweight adults. And also children show what type of food and environment that they live in, right? Because children don't cook for themselves, they don't shop for themselves.
What kind of diet would cause that? What would you be eating?
Ultra-processed food. So all our food has got processing. For example, mealie meal, we process it to be pap, right? From a corn. But ultra-processed is when you look at the back of a packet, all those words that you can't say, you know, the flavorants, the preservatives, and up to 40% of the average South African's diets is ultra-processed food. It is quite scary because you wouldn't think of having young children having non-communicable diseases. But look at the environment we're living in. We call that an obesogenic environment. Do you have places for you to play as a child or an adult? Safe places for you to exercise? What options you have when it comes to obesity care? So all those things, especially in a country like South Africa, where you've got a big gap between those that have and those that don't have, really push you into obesity. Then you're now having a generation of children in their teens and early 20s having type 2 diabetes, having hypertension. And that's a big concern because our healthcare system is not ready.
Moving on to solutions, Nomathemba, there's so much talk of anti-obesity medication. We all know Ozempic by now, and there are many other brands as well. Is that the solution to this?
The medications should definitely be part of the solution, especially when we're looking at the average South African, which is about 80 to 85% of the population that uses the public health service, that drugs should be made available. These drugs are able not to only reduce weight, but to reduce your risk of type 2 diabetes and heart disease.
And have you got any hopes for those drugs becoming cheaper?
I do, because we've seen this with HIV, where these drugs were very expensive at the beginning. They weren't available. And what happened was a combination of lobbying by researchers such as myself, advocates, governments coming to the party. And I think if we use that for obesity, and this is working together with originators, we're going to have generics in the market.
Research exposes a dangerous truth. HIV collides with obesity, heart disease, and other chronic illnesses, creating a ticking time bomb for South Africa's health system. Because treatment helps people with HIV live as long as those without the virus, they too now get diseases that become more common with age. So what does it mean to live with a non-communicable disease if you have HIV? For 30 years, Pholokgolo Ramothwala kept an uneasy truce with HIV. One pill a day kept his life as a health advocate, husband and father on track.
I tested in 1999. Mentally it was tough and there was not a lot of people who you could talk to. You have the internalized.
But as he neared 50, his body threw him a curveball.
I just felt tired. I couldn't wake up and I thought, okay, they are overwaking me. I went to one of the clinics at the mall and this nurse said to me, your blood pressure is way too high. Your sugar level is way too high.
A blood test confirmed the triple whammy: diabetes, hypertension, and high cholesterol. Diabetes is when your body can't control sugar in the blood, so it builds up and harms the body.
About 2 weeks back, I was in Cape Town, and they gave us lunch. I had not eaten in the morning, so I picked up a can of a cold drink, and I drank it. I was worried at the airport that I was going to collapse. I felt dizzy, I was weak. I had to check my sugar level, it was up. And in the morning, I had taken my meds. Then you get home, I'm struggling, and my family is watching. Mentally, it's hard. The diabetes is harder. I take about 7 pills throughout the day. My kids are used to me as Papa living with HIV. And when I tell them that I'm diabetic, my youngest daughter asked me first, are you gonna be on this medication for the rest of your life? People are not coping and they send me messages on TikTok. People who have HIV and diabetes, the stigma associated with HIV, people are not talking about it. Now there's diabetes, they're like, okay, I don't know what to do.
What are you having for breakfast?
My lunch, breakfast today.
From meals to workouts, Pholo's life has become a series of choices.
What I eat is important, which I do religiously. Exercising, even if I don't go to gym, I average 10,000 steps. Physically, I try to do as much as possible to try to remain healthy. Currently, I'm supposed to lose weight.
He can't imagine his future or his mental health without his wife and kids.
She struggled a little bit in the beginning, but now she checks, what do you need? What are you eating? I don't think I appreciate it enough for doing this with me. If she was not there, if my kids are not there, I don't know. I actually wonder how people deal with it.
We live in a country with almost 8 million people with HIV. If we compare how common obesity is in South Africa to HIV, which one is more common?
We've put so much investment in HIV, rightly so, because it was seen as an emergency. But obesity, that is now affecting 24 million people, women more than men, and that's set to double by 2030.
That is terrifying, the figures, Nomathemba. But you've mentioned we've made an investment, but one of the consequences of that investment, making HIV treatment available, is that people with HIV who use their treatment can now live as long as people without HIV. So there's more people with NCDs now.
We've turned HIV from a fatal disease to a metabolic disease. We're seeing people living longer, but in less good health, even if they're on ARVs. So people living with HIV are twice at risk of having heart disease, almost 4 times at risk of having type 2 diabetes. And this is something that we don't quite well understand as HIV researchers, but we know a few things. Using antiretrovirals, they are fantastic drugs, safe. But one of the things that we're seeing is that people who are using antiretrovirals do gain weight.
Why is that?
There are certain things that we don't understand, and that's why it's important for us to have trials here in South Africa. We've seen it in a lot of trials all around the world, but it's important that trials are done in populations that use these drugs.
Are there lessons that we can learn from how we've dealt with HIV, where we turned it from a death sentence into a chronic disease?
It's to use that same urgency that we used for HIV, it's addressing stigma. At the beginning of the HIV epidemic, people were so scared to talk about their disease. They were scared to go to the hospitals. At the same time, doctors and nurses and community members didn't know how to deal with this disease. Addressing HIV-related stigma opened the doors for many conversations to happen. We need to do the same for obesity. It's not about shaming people, making them feel bad, but really about helping people with evidence-based ways of dealing with their weight.
Nomathemba Chandiwana, thanks very much for joining us today.
It was lovely to spend time with you, Mia.
After the break, South Africa's health system is already under strain. But with long-term diseases like diabetes, cancer and heart disease on the rise, can it cope with what's coming next? You're watching Healthbeat. In South Africa, diabetes, heart disease and strokes are now among the top killers, fueled by tobacco, alcohol and sugary drinks. Taxes on these products could save lives and fund healthcare. But could it really work here?
Would you pay more tax to fight NCDs?
I definitely would be in favor of taxes, as long as it goes towards, research, towards finding better cures.
And I wouldn't want my future children to be in a situation where they have those diseases and they can't get help.
If it was accompanied by more investments in education on those diseases, so people knew why those taxes were in place.
We put the tough questions to UCT tax expert, Professor Corne van Walbeek. Corne, thanks for your time today. What are health taxes and why do we need them?
Typically, they are based on products that are perceived and experienced to be negative for people's health. And as a result of that, we want to make those products more expensive. And the way that the government does that is by imposing a tax on these products that will increase the price. The aim is to reduce the consumption of these products so that people don't get sick from tobacco-related diseases in South Africa, so that they drink less sugar-sweetened beverages. And all those things together result in a reduction in the health costs associated with these particular products.
Let's start with tobacco taxes. Have they had any effect on bringing down smoking rates?
In the early 1990s, approximately 32% of South Africans were smoking. That number dropped to about 20% in 2010. The reason for that primarily is because of an increase in the excise tax. Tobacco is highly addictive and tobacco is very difficult to quit. But what we have seen over that extended period of time, that many people have in fact quit, and a large number of people have not started smoking because cigarettes have become far more expensive over that period, especially from the mid-1990s through to about 2010.
But how do you know it wasn't the anti-tobacco legislation that was introduced in the 90s as well?
Legislation makes smoking socially unacceptable. It creates an environment in which non-smoking is the norm and smoking is out of the norm. What tobacco taxation does is it creates an additional incentive for people to reduce their consumption of tobacco by hitting them in the pocket.
So if you buy a box of cigarettes in South Africa, how much of that would be taxes? What proportion of the price?
Treasury each year changes the excise tax. At this point in time, the excise tax is 22 Rand and 81 cents per pack of cigarettes. An average pack of legal cigarettes in South Africa is in the order of about 50 Rand. So the excise tax is approximately 44% of the legal price of a pack of cigarettes. That goes to the Treasury, it goes into the general fund.
Who does it help most when it comes to a reduction in consumption?
Young people and poor people who don't have all that much money. They tend to be more price sensitive than older and wealthier people.
Why is that important?
Most people start smoking in their middle to late teens. Some people start in their early 20s. That's the most vulnerable period. So if one can discourage youth from starting to smoke, it means that that flow of people that are going to be addicted for the rest of their lives are simply not going to be there. From the perspective of poor people, the cost of smoking for them is much higher. When they become sick, they might not have the resources to be able to afford getting the appropriate healthcare, and something has to give. So as you are spending money on cigarettes, there's not money for food, there's not money for clothing, for schooling. So it's really not a smart thing to smoke.
One of the arguments that tobacco companies almost always raise is that as soon as you increase the health taxes, you will see an increase in the illicit trade of tobacco. How valid is that argument?
More than 50% of cigarettes currently sold in South Africa have not paid the full tax. And that is a very, very significant problem, and that's a major cause of distress for the public health community because it makes cigarettes cheaper and it allows people who would otherwise not be smoking to buy these cheap cigarettes. So from a public health perspective, these very cheap illicit cigarettes are really, really harmful. At the same time, it's harmful for the fiscus because the government doesn't get the revenue. Where the tobacco industry argument falls apart is that it is not driven primarily by excise tax increases. Illicit trade is a criminal problem, and in South Africa that has not been addressed. Illicit trade has been greatly boosted through policy failures by government that allowed certain parts of the industry to greatly expand illicit trade.
How do we fix the illicit trade then?
Law enforcement is vital, and our frustration is that there are mechanisms in place that we can use. Many countries have got track and trace systems in place, which basically means that on every pack of cigarettes you impose a tax stamp with a unique code that allows competent people to track exactly where that product is going to and also to trace it back where it has come from. And the evidence internationally suggests that if one has got a system like that in place, it's going to greatly reduce illicit trade. The tobacco industry gives an exaggerated number, but on conservative estimates, we think that it's about 15 billion rand every year that the government is losing from not being able to control the illicit trade.
Let's look at products that contain alcohol and sugar. Have you seen a decrease of the percentage of alcohol that a producer would include because of excise taxes?
What we have noticed over the past 25 years is that the alcohol industry have developed low alcohol beers. Castle Light has got 4% alcohol, whereas normal Castle has got 5% alcohol. Now it's become a very significant brand. So what's in it for South African breweries, which is the producer of Castle and Castle Light, is that they are having to pay less tax on that lower alcohol beer.
So a healthier product, but less money in taxes for the government.
Studies have been done both to look at the cost of tobacco and the cost of alcohol. And all those studies consistently find that the cost of these products to society is much greater than the revenue that the government gets in the form of excise tax.
Let's look at sodas that have a lot of sugar in them.
So we have a very interesting tax on sugary drinks. Before this tax was implemented, many of the sugary drinks, especially the sodas, were having a sugar content of approximately 10, 11, 12 grams of sugar per 100 milliliters of beverage. Because the excise tax is levied on the quantity of the sugar, many of these companies have reformulated their products to reduce the sugar content. The way that the sugar tax works is that the first 4 grams per 100 milliliters of beverage is exempt. So if you look on the nutrition label on your carbonated drink, you will probably find that the amount of sugar is 3.8 or 3.9 grams per 100 milliliters. That's not coincidental. The reason why it's 3.8 or 3.9 grams is it's below 4, and that means that the producer of this product does not have to then pay excise tax. So what the excise tax has done, it doesn't raise revenue. It forces or encourages behavior change on the producers. They have reformulated their products such that their products contain less sugar.
Has it resulted in fewer people buying those drinks?
Some studies have shown that there's been a decrease in the quantity of sugary beverages that have been consumed in South Africa. Similarly, in other countries, specifically Mexico, which also introduced this tax a few years before we introduced it in South Africa, there's been a significant increase in the quantity of water that people have consumed, and there's been a modest decrease in the quantity or the volume of sugar drinks that people have consumed over there.
Are those healthy ingredients that they replace the sugar with?
Usually it's artificial sweeteners. I know that there's a significant debate going on amongst nutritionists. Has this been a move in the right direction or has it not?
So if we get more health taxes, we have more money to use for health. What guarantees do we have that that money will be used for health?
National Treasury says we want to put all the money into a general pot. Then that's a negotiation between the different ministries and the National Treasury before the budget gets read in February of each year.
These health taxes are supposed to be used to improve the country's health. Why can't you just ring fence it?
Treasury doesn't like it. The general feeling is that you don't want to build unnecessary rigidities into a budgeting process.
Corne van Walbeek, thanks very much for your time today.
My big pleasure.
After the break, how do we convince gatvol South Africans to cough up more money for diseases like diabetes and cancer? In South Africa, even children are now being diagnosed with high blood pressure. The solutions are clear: better data, smarter prevention, and stronger hospitals. But how do we make that happen when public money is running thin? Dr. Mary-Ann Etiebet heads Vital Strategies, a global organization working in more than 80 countries with governments and civil society to turn evidence into action. Mary-Ann, thanks for your time today. Health taxes, in a recent report that you released, can be used to fill gaps in health budgets in African countries. How would it do that?
A recent report from the Task Force on Fiscal Policy for Health demonstrated that by just increasing by 50% the price of tobacco, sugary beverages, and alcohol, we would be able to generate over $3.4 trillion globally just from that revenue alone. But not only that, in 50 years, it would save 50 million lives.
How do you get governments on board to fight these industries and make these commitments?
One of the things that we must do is make sure that we're in dialogue with the public, raising awareness of these harmful commodities, harmful to folks' health, harmful, to the survival of their family, harmful for their economic security. In Africa alone, in the last 2 years, we've seen 10 countries actually move the needle on health tax by passing critical registration. So all the way from Cape Verde to Ghana to Zambia to Kenya have been successful in passing legislation. We need to create another narrative so that we can get the right information to the public. You have to make sure that you are continuing to work with civil society in coalition to counter industry narratives, because the industry doesn't let up just because the tax is passed.
To show how powerful the forces of these industries are, there was a United Nations General Assembly at the end of September, and there was a political declaration that countries, including South Africa, had to sign and negotiate the language on as to how to fight non-communicable diseases. And one of those things was to increase health taxes. And it's been watered down, disappointingly.
We saw specifically language changing from implement, have countries implement health taxes, to now have countries consider health taxes. And we saw the removal of targets. And we know that targets are essential because that's what helps us as civil society keep governments accountable. So countries can come together in solidarity against these harmful industries. What I think has become clear is that health is the foundation, not just for economic security, but for geopolitical security as well.
Mary-Ann Etiebet, thanks very much for your time today.
Thank you so much for having me on.
That's it for this September's edition of Health Beat. South Africa's health choices today will shape the lives of generations to come. We'd love to hear from you, so send us your thoughts and suggestions at health@bekesisa.org. Until next time, goodbye.